Alrighty, so I can start. We're good to go. Okay, so I just wanted to say hi, everyone. My name is Devin Hayward. I am the director of the Office of Diversity, Equity, and Inclusion, as well as the director for Gender and Sexuality Studies. I am also an assistant professor in sociology, urban studies, and anthropology. And so I just wanted to welcome you all to today's event. This is one of the first events for Women's History Month. And I think that starting off this conversation about making connections between Black Americans and Palestinians, especially in light of all of these recent events related to COVID, but then also having this event happen at the end of Black Women's History Week, which was founded by Feminista Jones. I think it really sort of highlights the deep connections that are occurring across oppressed groups across this planet. And so I'm very, very excited for today's discussion. Over the next couple of weeks throughout Women's History Month, we'll be hosting a series of events that are dedicated to telling the stories of women who are oftentimes excluded from these narratives. And so in 2 weeks, there'll be an event on Black women's involvement in the women's suffrage movement. We'll also be having an event next week to talk about immigrant women's experiences across time. And at the end of this semester, end of this month, we'll also be hosting an event on ancient women's contributions to art historically. And these contributions aren't going to focus on, Greco-Roman history. Instead, it'll focus on those communities and groups that are oftentimes excluded from ancient perspectives. And so again, for those of us who are at St. Peter's, look out for flyers, information as they become available. But again, I'm really excited to be helping to support a lot of these events that are coming up over this next semester, especially this month. But with that said, I will stop speaking and I will turn it over to, I believe, Carlette.
Actually, it's to Fatima, so I'll turn it over to Fatima so she can start us off.
Okay, because it was weird. It wasn't letting me unmute myself. Hi guys, my name is Fatima. I'm the president of the BAC. I'm also the president of Pride as well as the treasurer for the Students for Peace and Justice. So I just want to start off with some background information on why we're doing this event. We think that it's a very important event from a student standpoint because the number of Black Americans that are dying or being murdered due to medical racism here in the United States, and as well as the medical apartheid that's happening in Palestine, made us realize that this is an issue that has to be talked about. This is not a matter of controversy, but of human rights, and these issues need to be addressed. Also, there are structural and historical issues that need to be addressed, understood, and dealt with. Our Western education is most definitely lacking when it comes to this. And again, we just need to stress that this is a basic human rights issue, and it's not a matter of like controversy or politics. Now it's over to Carlette.
Hi, everyone. Good afternoon. My name is Carlette. I am president of the Students and Peace and Justice Club, treasurer of BAC and of Pride. So first, I would like to introduce our first speaker, Dr. Samah Jabr. She is a psychiatrist who practices in East Jerusalem and the West Bank. She is currently the head of the mental health unit within the Palestinian Ministry of Health and a founding member of the Palestine Global Mental Health Network. She has taught in local and international universities. Dr. Jabr often serves as a consultant for international organizations regarding mental health development. She is also a prolific writer and author of the book Beyond the Front Lines. This next part is in French, so bear with me. Derrière les fronts, Chroniques d'un psychiatre psychothérapeute palestinien sous occupation, which appeared in both French and Italian. And now turn it over to Janine.
Great. So I have the great honor of introducing Dr. Deirdre Cooper Owens. Deirdre Cooper Owens, an award-winning historian and popular public speaker, is the Charles and Linda Wilson Professor in the History of Medicine and Director of the Humanities in Medicine program at the University of Nebraska-Lincoln. In this position, Dr. Cooper Owens is one of 2 Black women in the US running a medical humanities program. Dr. Cooper Owens is also the director of the program in African American history at the Library Company of Philadelphia, the country's oldest cultural institution. As one of the country's most acclaimed experts in US history, according to Times Magazine, Cooper Owens is steadily working towards making history more accessible and inspiring for all. We're glad to have both of you here with us today. And we will start with Dr. Cooper Owens' presentation, if you would like to share your screen.
All right, I couldn't unmute. And also, so thank you all first for inviting me, John Jackson. This is how, I always make this jokes. My DMs pop on social media always about work. So people always slide in like, hey, can you give a talk at my school? So thank you, John, for sliding in and asking me that. I'm too old for anything else to pop off except for work. And so I have done some really wonderful talks via Twitter and Facebook and Instagram. And so I'm glad that social media actually connected me with you all. I see some familiar faces. And I also just thank you students for coming and allowing me and Dr. Jabr to share space together about an issue that affects all of us. Every human being has a medical life, and every medical life needs to be examined and understood with respect. So without further ado, let me share my screen with you. See, nope, it's not going to allow me to move. All right, so essentially I am going to speak a bit, and I've been given 30 minutes, so I'm starting now. Speak a bit about the intersections of slavery, medical racism, and gynecology. And I remember when I first started this as a dissertation project back in 2005, I remember meeting with archivists or talking to librarians, and they just couldn't understand why I was writing this book. They're like, surgical developments happened during the Civil War. Why don't you write about that? Or there's not enough information. There are not enough sources, because when you're a historian of slavery, you're essentially writing about people who were not allowed to become literate, right? And if they were not allowed to leave written records. And so that makes it really difficult to try to piece together this fragmented history about enslaved people. And so I thought, I always like a challenge. And I think that centering and privileging the lives of all people within American medical history is important. And most of the books had just been about doctors or institutions or diseases, and they were leaving out a really important segment, patients. And so I started on this journey. The ways that I like to discuss the past is in connection with the present, right? Why in the world are people interested in this, right? What resonates for us in the 21st century? And it really is this legacy of medical racism that comes out of the late 18th century and the 19th century in particular. And so I typically start off in this way, right? And I think this is really important. I would give talks. People don't do it do it so much anymore, but I would give talks and I would always have a couple of folks. Well, what you're talking about was then. Thankfully, this doesn't go on anymore. And I'm like, this is why I'm a historian, right? We don't just care about dates, we care about context. And so for me, it is providing the context of medical racism. So I start off with then. And this guy is a pretty easy person to talk about, Dr. Samuel Cartwright, because he becomes a kind of notorious figure because of the publication he was asked to write and research in the antebellum era by the Louisiana State Medical Association. So he wasn't just kind of thinking about writing this. He was actually invited to write an article about peculiar Negro diseases. And so Samuel Cartwright, who was certainly pro-slavery, he was a Southern physician, he conducts research during the time, and he finds that there are several peculiar Negro diseases, and one of them is called drapetomania. And it is the mental illness that afflicts enslaved people when they harbor the thought of running away or they run away. Another was enslaved people had a natural propensity to want to eat dirt, so he called them dirt eaters, right? Now, this is the thing. In the 21st century, the 20th and the 21st century, we know that when people are drawn to eat clay or dirt, it's not because they want to eat clay or dirt. It's because their bodies are essentially saying, you don't have enough iron, right? And so the condition of slavery essentially creates, in 21st century language, this kind of negative social determinant that, precluded enslaved people from having the kinds of nutritional diversity that they needed. I mean, there were all kinds of things, people who were knock-kneed, all of these kinds of peculiar diseases, right? And then he does something else that was really pioneering. In fact, it frames much of the medical research that happens in the United States today. Samuel Cartwright uses, and if you look to, I'm going to point here, it's the right of my computer screen, to a book cover by Brown University medical anthropologist Lundy Braun. The book is amazing. It's called Breathing Race into the Machine. And what Lundy wrote about was the spirometer. It's still used today, and it measures or assesses lung capacity. Now, let me tell you how Samuel Cartwright enters into the picture. He doesn't invent it, but what he decides to do is conduct a study of enslaved people and white people, and he assesses their lung capacity. And he really is the first person who is doing this kind of intentional race-based study, right? And what he finds is a Negro has diminished lung capacity. And in fact, it's so impressionable upon his colleagues and so influential that the Union Army in 1864 takes up this study and does it, right, in service of the United States. And they find that the Negro has a lessened lung capacity. Now, how does this work in the 20th and the 21st centuries? So it is considered a pre-existing condition for Black people, right? That we have this diminished lung capacity when compared to white people. Now, what these studies back then and even now don't take into account are the social determinants, right, of a negative medical outcome. If you are measuring people who live in slave cabins that are not insulated, that are not ventilated, that have chimneys, smoky chimneys in the house, of course they're going to have a diminished lung capacity, right? They can't just open up a window and those kinds of things. If you're talking about people who are forced to live in overcrowded areas, there are issues with sanitation, all of these kinds of things, of course there's going to be diminished lung capacity. It has nothing to do with the kind of natural biological difference that Black people supposedly have from white people. The thing is, if I literally breathe into the machine, and I have a white woman who has basically the same stats, age, weight, all of those things, right? And she breathes into a machine. In 2021, a medical doctor has to press a button for Black or white. And even if we have the same readings, that Black button is going to recalculate the actual function for my race. And so, I mean, there's a long history, right? Higher insurance premiums, all of those kinds of things. That's the legacy that we're talking about. And for those people who continue to ask me, well, I don't understand. In the 21st century, this can't be. I was like, but let me pick on UVA. And the reason I pick on UVA is not because it's a bad school, but I went to the school, right? So if anybody's like saying she's biased, I'm like, I did my postdoctoral fellowship at UVA. UVA is considered one of the country's most elite schools, founded by Thomas Jefferson. It's really hard to get into their medical school, which is considered one of the elite medical institutions in the United States. I also like to point out that the students who are entering into UVA's medical schools, these are not people coming straight from high school. These are people who have received undergraduate degrees and training. Now, in 2016, Kelly Hoffman, who's now a doctor, but was a doctoral candidate, was heading up a research team, and she was interested in perceptions of pain. And so she does this study in 2014. It's published in 2016. Some of you may have read about Dr. Hoffman's results. Overwhelmingly, white medical residents, students, and even some physicians believed in an inherent biological difference between Black and white people. She also listed conditions that were painful in these kind of hypothetical cases. The only difference is one patient was Black, one patient was white. Overwhelmingly, these white medical doctors, interns, and students believe, oh, Black people don't suffer from pain, and if they do, it's pretty, minimal. Black people age faster naturally, biologically. Black people have thicker skin. Black people's nerve endings are less sensitive. This is in the 21st century. This study will be 5 years old next month. It is new. And this is the thing, it doesn't tell us anything that we don't already know. There had been studies about this from Harvard, from schools in Europe, right? University of Chicago. And so I'm literally trying to tell people, these students, these residents who entered into one of the country's most highly respected schools are coming in with ideas that mirror those of Samuel Cartwright in the 19th century, right? In the 21st century. And so that proves damaging to the health care of Black people in particular. So that's a little bit of, the kind of legacy of medical racism that I've had to really discuss and confront. But most people are really interested in SIMS, and there's a lot of misinformation about SIMS. And so, for me, it's about the ways that this misinformation has circulated, but also, I think as a historian, how we can situate SIMS within this whole discussion of medical apartheid. So I was first brought into this in 2017, and I was brought into the situation largely because I was still teaching at Queens College in New York, and my book was just about to drop. And in August 2017, 4 Black women from the Black Youth Project 100, the New York City chapter, staged artistic protest. The woman in the head wrap, Jewel Cadet, was the one who organized it. And the picture went viral. Many of you might have seen this picture. And when it went viral, it really amplified the work of some of the East Harlem local activists who had been trying to get the SIMS statue removed from Central Park. It was in East Harlem at the easternmost part of the park, right across from the New York Academy of Medicine, where SIMS, known as the father of American gynecology, had been a former president of that institution. And so this also was a part of the political moment in 2017. Many of you remember there were students all across the nation, but largely in the South, who were protesting the statues that had been dedicated to the honor of Confederate soldiers in the Civil War, and they wanted those statues removed. And the North was kind of like, we don't have that problem because we're the North. And these folk were like, yes, you do. What about this statue of SIMS? So my press decided, you know what, as my editor said, we're going to ride this political wave. We're going to release your book early. And almost overnight, I'm no longer an assistant professor of African-American history at Queens College. People are like the foremost historian on James Marion Sims. And I knew I hadn't written a book about SIMS. I wrote a book that was centering the lives of enslaved women, right? Even the title, Medical Bondage, lets you know that the history of US slavery was central to the development of American gynecology. And so I really fought against this kind of framing of SIMS as the historical boogeyman, not because he needs my defense, but because it does a disservice to what structural and systemic medical racism is. If you pin everything on one person, we then forget that this was a structure. And we also do something that makes SIMS exceptional. So some of the information was SIMS created the idea that Black people didn't experience pain, or Black women didn't experience pain in childbirth. No, we didn't. That had already been in existence. SIMS literally inherited a cultural practice and scientific and medical knowledge that stated this well before he was even born. And also these ideas that SIMS was intentionally mangling the body parts of enslaved women. No, he wasn't. SIMS was a slave-owning physician. And let me tell you all something about slavery that lots of folk don't know. Slavery literally changes the game in terms of how Black women had been exceptionalized. SIMS wasn't exceptional. Black women's treatment was exceptional in this country. And you can go back to the 1680s in the British colonies, right? And I'm just focusing on Britain, but you can look at some of the other European empires that came over and colonized what becomes the United States. But in these these colonial edicts, these white men who were interested in wealth, right, and the creation of more wealth through land ownership and the ownership of human chattel, which enslaved people were considered chattel property, movable property. What they did that literally turns everything upside down. They say, we'll make a rule that if an enslaved woman gives birth, the condition of her servitude is passed on to the child. In no European society for millennia had that ever happened, right? The child always inherited the status of the father. But because slavery was such a lucrative economic labor system, what becomes the United States, ever since the 1680s, Black women were essentially exceptionalized in this way. So they are the ones who have to have their wombs maintained and their reproductive capabilities maintained by the state and the medical establishment, not because they care about Black women, but because slavery's propagation is literally like inside the healthy wombs of Black women. So Sims, as a slave-owning physician, is not going to lease these slaves to experiment on them to make them infertile. It doesn't make any sense for a slave owner to do that, right? And so trying to get people to really understand that part of slavery, was also a part of my job. So I started out with this leading question: was Sims exceptional in his treatment of enslaved women? Lots of his defenders were like, this man was exceptional because he did all of these things. And I'm like, so did lots of other men. Once again, the nature of something that's structural is not that one person, right, it stands out. You literally see that there's a template being made. So I start in the 18th century across the pond with Georges Cuvier. I'm interested in him because of the work that he does on Saartjie Baartman, who was derisively known as the Hottentot Venus. She was a Khoi woman born in South Africa, and essentially becomes very famous because of the size of her buttocks. That's it. Even medical doctors pathologize the size of her buttocks, calling it a medical condition, the enlargement of the buttocks, steatopegia, which is still used today, right? And he dissects her body because he thinks that she's the missing link between humans and primates. Guess what? He found that she was just like any other human being. But for me, I'm less interested in the kind of social capital people, in Western Europe put on Saartjie Baartman. I'm looking at the way she was treated as an example or an exemplar of doctors, right, in this Atlantic world, writing about her, treating her, the ways that even in the afterlife of her being owned and displayed, she was still put on display. Because when Cuvier performs this autopsy, cuts out her brain, he preserves it, puts it in a bell jar, boom, it goes on display in the National Museum of Paris. Cuts off her genitalia, preserves it, puts it in a bell jar, it's displayed in the National Museum of Paris. So were her skeletal remains. And they remained on display until 1974, until the 20th century. She died in the 19th century. But what this taught me, right, as a historian of slavery and race and gender and all of these things, is what's the worth of Black women's body parts, even in the afterlife of slavery, that they're still worth in the medical world, right? Because they're seen as other. Ephraim McDowell is the next person I talk about. Known as the father of the ovariotomy. A lot of folks don't know about Ephraim McDowell. He was a slave-owning physician, born in Virginia, moves to Kentucky, and he essentially has the first recorded abdominal incision, successful surgery where he removes an ovarian tumor from a white woman that was over 21 pounds. And then he decides, wait, I think, because the woman lives amazingly. This is 1809. Most people during this time would have died, and all people would have died, right? So he does this amazing thing, and he thinks, I have to perfect this surgical technique. So he, in Kentucky, where in the 19th century, there were still not a lot of Black folk. In the 21st century, there's still not a lot of Black folk in Kentucky, but he finds 5 Black women who he suspects, are suffering from ovarian tumors. And he performs experimental surgery on them, right? Over a number of years, and publishes it. So I'll talk a bit about him in just a minute. John Peter McTower, known as the father of American plastic surgery. In fact, almost 10 years before Sims, he performs the same surgery as Sims. Sims actually read his article And most people know Sims as this historical boogeyman. And I'm sitting here like, do you all even know the surgery that he performed? It was an obstetrical fistula surgery. Back then it was called vesicovaginal fistula. It affected all women, you know, and essentially it's a trauma that's created from childbirth. And there's tears that's created in the upper vaginal area as the mother is trying to expel the fetus. There's all of this friction happening, and fistula or holes are formed, and the bladder is right above that. So incontinence is the result. And if there's tearing in the anal area, there's also incontinence there. So John Peter Mataro does this experimental surgery on a Black patient, a white patient, right? I'm like, why aren't we talking about him? And then Francois-Marie Prevost, French-born, known as the father of the C-section, he performs experimental surgeries on enslaved women in Haiti, literally C-sections. And when the Haitian Revolution starts, he skedaddles and goes to another former French colony, Louisiana, begins the same experimental surgery. And the legacy of that experiment, where we don't even know his name or this work, is that Louisiana, up until the 21st century, at one point it was number one. Now it's one of the top states where Black women have more C-sections than any other racialized group in the country, right? And so I'm sitting here saying, what we just blaming Sims? Like that's what we're doing? No, that goes against the very nature of something that's structural, right? That one person doesn't create this. This was already being put into place. And so Sims is being taught because of the work that these men create, right? Through their publications, through the men that they trained, right? In medical schools. And so it's a much bigger issue. So Ephraim McDowell, and I'm looking at my time here. I have about 10 minutes. I'm going to speak fast but clear. I told you all about the work that he does removing these ovarian tumors. So to go to the enslaved women who he experimented on, he experiments on 5 in Kentucky. One of them dies, unfortunately. We don't know which one. 4 of the 5 were enslaved. He finally writes an article, publishes his article 8 years later in 1817. And one would think, oh my gosh, this new nation known as the United States is going to finally be put on the global map as more than just this kind of experiment in a republic, democracy, all of these kinds of things. Maybe they'll see that this country, has some value, right? And so he publishes this article, and guess what? He is derided. In fact, a leading physician in England writes in the Lancet, well, of course, these women could bear the pain, right? These negresses would bear the pain. They bear cutting with the impunity of dogs and rabbits. So once again, this idea that Black women don't experience pain. Well, of course, he picks a hardier species, a hardier specimen, right, of human beings. And this was in the early 19th century, right? And this is coming from across the pond in England. These ideas had already been circulating about biological difference. If we think about John Peter Mataro, this pioneer in obstetrical fistula, John Peter Mataro publishes his article on vesicovaginal fistula. And he takes a Black woman who's enslaved and a white woman who obviously is free in Virginia. And he performs the surgery using a silk suture technique, right? So he's essentially using silk material to suture up those fistula or holes. And he tells the white woman, okay, you need to rest up. Miraculously, as he writes, she's fixed, she's cured. The enslaved woman isn't. And literally, as he says, for 8 clinical trials, he tries every technique he can, and the Black woman just cannot be cured. And he writes in his article, and you can tell it's a moment of frustration for him as a doctor. He can't understand. He applied the same technique, and he writes, the patient could have been cured had she stopped engaging in sexual intercourse. Sir, you're a Virginia slaveholder. You understand that chattel property don't own themselves. What enslaved woman can say, actually, I don't want you experimenting on me. And number 2, I am going to stop engaging in sexual intercourse. What if she's being forced? What if she has an enslaved man that she is in love with and that she's sharing intimacy with him? Enslaved people don't legally own their bodies. And so there is no way that she could have stopped it, right? And so when we think about this practice of patient blaming, I'm telling people, open up an 18th or 19th century medical journal, right? We're calling it patient blaming now. But once again, when you start to see that this is the normal language, when there is a negative health outcome, it is always the patient's fault, right? And then James Marion Sims. I serve on a lot of panels, I give a lot of talks, and once again, people assign him, a lot of things that he just didn't do, right? And so it's not, once again, James Marion Sims is dead. He does not need Deirdre Cooper Owens to defend him at all. But for me, I'm like, why don't we focus on the things, right, that actually mattered in his day? So a lot of times people will say, he performed surgery on enslaved women without their consent and without anesthesia. And I have to say, most surgeries performed in the 1840s, physicians didn't employ anesthesia. It didn't matter, man, woman, Black, white, Native, it didn't matter. Because guess how doctors found out a patient was still alive? The patient moved, the patient screamed. And so in 1844, when he begins the experimental surgeries, he doesn't do so because he necessarily wants to torture these people. He does so because he enters into a legal binding contract with these women's owners, where he leases these women and he tells the owners, I am going to fix your, basically your slaves at cost. The defenders of Sims says, but look, he gathered up these women at his own cost, and he took care of them for 5 years in his home. I'm like, have you ever heard of hiring out? The two most famous enslaved people who talk about being hired out during their lives, Harriet Tubman was first hired out or leased at 6 years old. Frederick Douglass talks about being leased or hired out, right? So this is a practice that slave owners had been doing for centuries, right? So he gets these women. We only know the names of 3, Anarcha, Betsy, Lucy, but there were about 6 others, 5 or 6 other women during that time who were being experimented on. And so he doesn't use anesthesia because anesthesiology was not a branch of medicine then. People who had access to anesthesia and used it typically were dentists. Most doctors didn't believe in putting people in twilight sleep because they were afraid patients would bleed out. And so it's horrendous for us to think about today, being cut open and conscious, but this was a regular practice in the antebellum era, especially during this time in the 1840s. The other thing I've already talked about, he is leasing these men's property. He is not going to intentionally mangle with the understanding that, in fact, maintaining these women's reproductive capabilities increases wealth for the slave owner. The other thing, he intentionally drugged them with opium. Guess what doctors did in the 19th century? Whenever you wanted to stop a suture from breaking, you gave opium because it creates constipation. If you read anything about Civil War medicine, the first, kind of widespread drug epidemic happened because doctors in the Civil War were giving all the patients opium. I mean, but these are things that, once again, just as Janine spoke in the beginning, and Professor Devin, Americans don't know about this because it's not taught. And so we make these kinds of presumptions based on our 21st century knowledge. If I had written a book about James Marion Sims not getting consent from slaves, the book wouldn't have been published. How do you ask consent from someone who is not legally considered a human being? And even if the enslaved person said, I do not consent to this experimental surgery, what slave owner is going to listen? He didn't go to the enslaved women and say, hey, leave your slave farm or plantation and follow me. He went to the owners. That's who gives the consent. And so there are these things where in the 21st century, right, we harp on, and I'm saying, let's look at the implications of the actual 19th century. Sims is very transparent in his writings. He writes in his autobiography called The Story of My Life, around 2.5 years of this experimental surgery, right, that he's doing, his 2 white medical assistants quit, and the townspeople, he says, withdraws their support. So he has to now make his enslaved patients his nurses and surgical assistants. So I'm thinking, wait a minute, there's something to this, right? He just kind of does it as a story of, his kind of dogged determination. As a historian, I have questions. So I look at the 1850 census, and I'm trying to find out something about these enslaved women. And this might be an ethical issue of why folk withdrew support. Sims hints at some people kind of whispering that he was experimenting on the women like guinea pigs. But I'm looking at these enslaved women. The census can't tell you much about enslaved people outside of sex, race, age. No names, you don't know their favorite colors, nothing, right? They're listed as property. So I know 5 males exist on the slave farm during this time period. They're all children. So one can assume that they're the children of the enslaved women. So the other 12 that are either older, outside the age of giving birth, or young children themselves. The youngest person on the slave farm is 2 years old and listed as the only mulatto. The little girl was born during the experimental trial around the same time Sims says the white community withdraws support. And she's the only one who is so markedly different in her appearance that the census taker out of 16 other enslaved people marks her as mulatto. Now, I cannot say Sims was a father, but what I do know is Sims had possession of this woman's body for nearly 5 years. So if it wasn't Sims, some white man had access to this woman's body during a moment where she was supposed to be healing and not having sutures broken, and she's impregnated and gives birth to a half-white child. I was the only person who actually paid attention to the census from the perspective of centering these enslaved women. Everybody else just said, oh, he owned at least 17 slaves. That means he was a man of middling sorts. And for me, I'm like, well, if you kind of pivot your attention, right, to the patients, to these Black women, it can reveal a lot. So we don't know paternity, but we do know that there was something unethical going on, even by 19th century standards. And so Sims does a lot. He has a slave hospital built. This is an 1895 picture of that original hospital. He creates, he doesn't invent the speculum, but what he does is he creates this speculum that still bears his name, that was essentially forged in the bodies of these enslaved women. And even when articles were published and he writes about enslaved people, the editors make the patients and the nurse white. So now there's a literal erasure. His narrative is about Black people, but all the images you see are about white folk. And so this is telling me my time is up. So now we're left with this legacy of medical racism. We know the stats, right? The Black maternal health crisis is 3 to 4, it means that Black women are birthing people 3 to 4 times more likely to die from pregnancy complications. And what we know is not race, it's racism. Rachel Hardiman, an associate professor of the University of Minnesota School of Public Health, literally conducted a study of over 1 million cases in Florida. And when Black women and birthing people had Black doctors, midwives, and nurses, guess what? That maternal and morbidity rate for mothers and birthing people and their children was cut in half. So when we literally think of Black women and birthing people as not objects, right? That we should disrespect, but actually subjects who require our care and our humanity, then we can have these real conversations about how to finally dismantle medical racism. So I thank you for your time, and I look forward to your comments and questions.
Am I supposed to transition or? Oh, Toya, sorry.
Sorry, I couldn't unmute myself. But thank you so much, Dr. Cooper Owens. That was like mind-blowing information that you shared with us. And I'm sure that all of us appreciate it, and we all will have a duty to now educate ourselves more on that. Next, we're going to transition into Dr. Jabr's presentation. If you can, and want to, you can share your screen.
Thank you very much to Dr. Owen, and thank you for the organizers for this wonderful event, which is very important. And actually, The history that Dr. Owens spoke about paves the way for me to explain the reality in contemporary Palestine under occupation. I will be speaking in general about pre-existing conditions before the COVID-19 and focusing my attention on what's taking place in Palestine during the pandemic. We heard Dr. Owens speaking about social determinants of health, which might be known to all of you, but I want to start with simple definitions so that I will be clear in the things that I will discuss later. So we are talking about conditions in which people are born, live, work, and age, like education, like healthcare, social community context, economic stability. Those are the social determinants of health. And in Palestine, we have social and political determinants of health. Also, I want to define health indicators because I will be speaking about them. That's a measure designed to summarize information about a given priority topic in a population health or health system performance. And this is the geography of Palestine, occupied Palestine. We see over the years how the land has been shrinking, and it's a story of the expulsion of 2/3 of the Palestinian people. So when we talk about Palestine now and the health status for Palestinians, my discussion is focused about the Palestinians living in the occupied Palestinian territories, Gaza and the West Bank. We see the geographic fragmentation of Palestine. This is Gaza, a highly dense and highly populated area. And this is the West Bank. And we see in the West Bank, within the West Bank, there are different geographical territories. Some are controlled by the Palestinian Authority, some are mixed in their control. Israelis have military control and the Palestinians have administrative control, and some are completely under the control of Israelis. A few months ago, the Israelis were speaking about the annexation plan, and that is taking over 60% of the geography of the West Bank, which leaves a small percentage of the historical Palestinian land for Palestinians. We're talking about 8 to 9% of the Palestinian geography. I want to discuss the pre-COVID-19 health disparities, the very contemporary ones. I don't want to go, I'm not a historian, I'm a medical doctor and a psychiatrist, so I will focus my discussion on the reality that I witnessed. So the disparities are seen in infant, child, and maternal mortality, life expectancy, mortality rates for leading causes of death, and measures of mental well-being. Different social determinants of health are responsible for discrepancies between Palestinians and Israeli health indicators. The reasons for these disparities are a complex mix of economic, nutritional, environmental, psychosocial factors, as well as differences in the quality of and access to health services. Again, we cannot blame it on the race. It's the conditions under which people live. The title that you gave for this event is Apartheid. And I think there are differences between military occupation, settler colonialism, and apartheid. I don't want to get into that, but I want to explain a little bit the fragmentation of the Palestinian people. The occupation created different Palestinian communities. So we have Palestinians, 1/3 of the Palestinians are living in Gaza and the West Bank, 3 million in the West Bank, 2 million in Gaza. 2/3 of the Palestinian people are either expelled outside Palestine as refugees, or within Palestine. There are also in Palestine refugees. We have a small population living in East Jerusalem. I come from East Jerusalem, and we are residents of Jerusalem of the state of Israel, but we don't have any citizenship. We're not Palestinian citizens or Israeli citizens or citizens of the world. We don't have any kind of citizenship. And we have a special system for us. And there is also the Palestinians with Israeli citizenship, who were the few people who remained in the land in historical Palestine when the events of the Nakba, the catastrophe, the expulsion of the 2/3 of Palestinians took place. 100,000 people stayed there and they accepted the Israeli citizenship, and now they make 1 million people. And I'm talking about different categories: Palestinian Jerusalemites, Gazawi, people from the West Bank, Palestinians with Israeli citizenship, and Palestinian refugees. And they have different health systems and different psychosocial conditions and contexts, and different political and social determinants of health. But the situation that I will be talking about is the situation in the West Bank. We can say that what exists within the Israeli territories between Palestinians who have an Israeli citizenship and Israeli Jews is apartheid. And this also applies to Palestinian Jerusalemites. But what exists in the West Bank is military occupation. So the military occupation creates, sustains, and contributes to health disparities, directly or indirectly. Directly by causing psychological distress, environmental hazards, and obstructing access to medical providers. Indirectly by retarding economic growth, disrupting social functioning, and hindering efforts to improve healthcare and public health. Let me give one example, some concrete examples. In Gaza, a woman might have a low grade of breast cancer that can be curable, but because she is a relative of someone who is blacklisted by the Israeli occupation, she cannot leave Gaza for treatment. And her treatment is not available in Gaza. So the political situation can determine the prognosis of that woman. Her health condition will deteriorate and she will die even though her disease is curable. This is the picture of military occupation. This is what it means. One interesting piece of information about Palestine: 20% of the Palestinian people experienced political imprisonment, and torture and maltreatment, mistreatment is a very common experience when people are detained. We can imagine the psychological consequences of this experience on the individual, on the family. Most of the people who are arrested, they are arrested when they are adolescents, the first time. And then the relationship to political prison becomes like a revolving door. We can imagine the effect on the individual, the family, and the community. This is another example to represent what it means, a military occupation. This image comes from Gaza 2014, where massive demolition and de-development took place. When you look at the picture, you might think there was an earthquake there. The difference is that an earthquake does not mean to humiliate you or to break your schema, your belief system. But the acts that are done by military occupation, they are deliberate to break the belief system of individuals, to break the psyche of individuals, and to break the connectedness within the society. So we're talking about one geographical area that we call Palestine and Israelis call Israel, but we have different realities in the same geographical place. In 2017, per capita gross domestic product was 40,000 for Israelis, 3,000 for Palestinians. Unemployment rate in the Palestinian territories was 28%, while it was 4 for Israelis. For youth, the discrepancy is even bigger. Deep poverty rates, which means unable to meet minimum requirement for food, clothing, and housing, it was 34% in Gaza, and unemployment rate was 52%. Nutrition, that's also another determinant of health, important one. The prevalence of severe food insecurity in the occupied territories was over 8 times than in Israel. It's about 59% in Gaza, food insecurity. Malnutrition is a greater problem in Gaza compared to the West Bank. Childhood stunning is 13%, childhood anemia is 25%, and also anemia is very high among women in the childbearing age, and we can imagine how this affects the growth and the well-being of their children. Excuse me for the slides, I'm not very good at drawing tables, so I used some copies of tables that are already published. I will explain here. This slide shows the difference in life expectancies for Israelis and Palestinians over the past 20 years. And we can see that all through the years, there is almost a 9-year difference in the life expectancy between a Palestinian and an Israeli. And this table shows child mortality rates and the difference between Israelis and Palestinians. And we see that children die from 5 to 10 times more than Israeli children. The same goes for maternal mortality rates. The difference over the past 15 years, 20 years was also very important. It's like 5 times between Israelis and Palestinians. Those are the leading 20 causes of death. And we see that the mortality rate difference between Palestinians and Israelis for the 20 leading causes of death, like ischemic heart diseases, brain diseases, some cancers, cirrhosis, road injuries. And we see that the Palestinians are, they have like 2, 3, 5 folds more than Israelis. Also within the Palestinian community, the environmental risks are more important: air pollution, lead exposure, and that explains some of the illnesses and the diseases. The hazards like the Wi-Fi support system and the waste is distributed within Palestinian areas to serve the Israeli neighborhoods. Food insecurity, we see that diseases that are related to dietary factors, there are important differences between the Israeli and Palestinian population, and we see the statistical significance. There is a statistically significant difference between for some conditions like ischemic heart disease, stroke, and diabetes. Let me summarize also some important differences when it comes to resources. This is the data for 2019, 2018, and it shows that on average, $300 are spent on the health of a Palestinian, while more than $3,000 are spent on the health of an Israeli person. The number of physicians is 3 times on the Israeli side than it is in the West Bank. The number of midwifery and nursing personnel is also 3 times the number on the West Bank. And hospital beds on the Israeli side are 3 times more than what we have in the West Bank. In addition, like most of the important machines and expensive machines are available on the Israeli side, but not for Palestinians. And we cannot obtain a PET scan, for example, without the permission of Israelis. And often they don't allow resources and big machines and important equipment to arrive to the Palestinian side. The process is very slow, is very tiring, and it gives them the monopoly of being a referral system for Palestinians. Of the money that Palestinians spend on their health system, there is about 20 to 40% money that is spent on the Israeli side to refer the Palestinians to the Israeli side so that they will do further and more sophisticated investigations. That is the situation before the pandemic. The pandemic multiplies the challenges for Palestinians. This is the picture. Those are the latest information about how Palestinians are affected. Palestinians in the occupied Palestinian territories are affected by the pandemic. So by today, we have like 2,300 deaths, and we have around 200,000 people affected. But we know that these numbers underrepresent the reality because we don't have sufficient testing kits. And here, let me show you an important image. This compares the curve for Israelis and Palestinians. The absolute numbers are higher on the Israeli side because they have a bigger population, and also because they do more testing than we do in Palestine. But what is interesting here is to see the waves. So we had the first wave almost at the same time, Israelis and Palestinians. And then we had the second wave almost at the same time. But here we see the drop within the Israeli system, among the Israeli population, and we see a third wave for Palestinians because Israel is leading the world in vaccinating its population, while Palestinians are not yet vaccinated because Israel is not allowing the vaccine, not taking responsibility as an occupying power to stop the pandemic, and I will come to discuss that soon. So the numbers are
You share the
growing.
screen now.
Sorry?
I can do it now?
Sorry?
Don't worry. I think he was doing something else.
Sorry. Okay. So we see a third wave on the Palestinian side while things are improving on the Israeli side because of the vaccination. And let me talk about how we survived the pandemic. At the beginning of the pandemic, everyone was talking about staying at home, being in quarantine, confinement, and social isolation. But in the refugee camps, people live like that. In Gaza, the population is very dense and homes are very crowded and there are no playgrounds. To tell somebody, stay at home, if you're affected, stay at home in your own room and use the toilet, don't mix with others. That is impossible for the vast majority of Palestinian people, not only in the refugee camps and in Gaza, but also for Palestinians in Jerusalem, where life is very expensive and homes are very tight and small because of the long policy of a demographic engineering of the Palestinian people to kick them out of East Jerusalem. Those are the characteristics of the Palestinian people. It's a very young population. 48% of the people are children, are below 18. We have prevalent chronic diseases at a young age. People at the age of 30, 40, they have obesity, hypertension, diabetes. We have a very fragmented health system given the fragmented geography. We don't test enough because we didn't have enough testing kits, and also because people worry about breadwinning, because they are afraid if they test positive, they will be prevented from going out. And many people survive on daily basis. If they stay at home because they cannot work, no one will support them financially. So we estimate that the real numbers of affected people are much higher, and dead people are much higher than what was announced. So there are quite a lot of unidentified cases. Among the pre-existing difficulties that are special also to this period is the fact that the American administration punished the Palestinian Authority during the time of Trump because the Palestinian Authority refused, and the Palestinian people refused the deal of the century. So there were important cuts of the aid that was given to Palestinians, and that was the funds that was given to the UN Refugees Agency and their services of education and medicine and health services, as well as for the Palestinian hospitals in Jerusalem. And the pandemic arrived at a time when we had a crisis at the level of medical services because of the punishment, because Palestinians were punished for their political behavior. We have an underserved mental health. So there are deficiencies in the whole health system, but especially the mental health system. And it took the Palestinian policymakers a while to understand that mental health system need to be served and need to be, services need to be provided as much as the physical health to Palestinians, because in this pandemic, people suffer physically and psychologically. We have a wide community of laborers who go to work in Israeli settlements, Palestinian laborers, or Israeli areas for living. And those are the people who, if they don't go to work, no one will pay them. And like that, they will lose a lot because they are affected by the virus, if they announce that they are affected. And we have like 5,000-6,000 Palestinian prisoners who were affected while they were in the Israeli prisons. So we have a fragile system, as explained earlier, but at the same time, the international community was complimenting Israel and talking about its generosity on two occasions. At the beginning, when Israelis allowed samples, small quantities of disposable material and kits to arrive to Gaza or to arrive to the West Bank, even though they gave few donation and they allowed some donation from Qatar and other countries to go to Gaza. They allowed the WHO to bring some material. And also at the beginning of the pandemic, Israel returned some of the withheld tax money that belongs to the Palestinians. And in reaction to that, instead of talking about the Geneva Convention and the obligation of the occupation in the time of pandemic towards the occupied people, the mainstream media in the world was giving compliments to Israel for its false generosity. The second occasion was the time of the vaccine. Of course, there was a very racist discourse among Israeli politicians when human rights organizations cried that people in prisons are affected, prisons are crowded, you should vaccinate the Palestinian prisoners. There was formal Israeli refusal, then 120 local and international health organizations launched and mobilized a campaign that resulted in the vaccination of Palestinian prisoners, like one positive step. So, and at the same time, Israel is putting obstacles for the vaccine to arrive to the Palestinian Authority. Until today, by today, there are only 12,000 vaccines that arrive to the West Bank and 22,000 vaccines that arrive to Gaza, while the majority of Israelis are vaccinated by now. Over the last couple of weeks, I lost 3 of my colleagues within the medical system because the vaccine is late to arrive to Palestine. And it's very sad because we see people losing their lives. I know pregnant women who lost their babies, many people who are getting affected badly by this situation because the vaccine is coming late to Palestine, or Israel is putting obstacles in the face of this vaccine. I want to remind you of the Article 56 of the Geneva Convention. You can read it, but it talks about the obligation of the occupying power during the time of pandemic. It has the obligation to protect the occupied people, because Palestinians don't have borders. We cannot control who comes to our territories and who doesn't come to our territories. We don't have a sovereign economy. We depend on donation from the international community, who give us the donation as a bribe to change and manipulate our political agenda, and on the tax money that is collected by Israel, and Israel decides to withhold or give that tax according to the Palestinian political behavior. So it's a very critical situation. And by refusing and denying the obligation to the Geneva Convention, Israel is denying the fact that it is an occupying power. And also, when the international community compliments Israel for allowing some material to arrive to Palestinians, they are also denying the situation of the occupation. And that is the bottom line. I think it is a time to declare the reality that Israel controls the Palestinians. They withdrew from Gaza, but they besiege Gaza. This is the 15th year for Gaza to be besieged since the Israeli withdrawal from Gaza. And they control most of the territory in the West Bank, but they can enter every morning to any village, to any neighborhood in the West Bank and arrest whoever they want. But yet they don't take their responsibility as an occupying power. Here is an example of the recent detention that is taking place. So those are Israeli soldiers wearing the disposable material, but they are also having their guns, and they go to the homes to arrest Palestinians. During the pandemic, the occupation continues, detention, demolition, annexation plans, all of that continues. Mental health is also the invisible part of the pandemic. It has sown the seeds of the COVID-19 pandemic, has sown the seeds of a mental health crisis around the world. In Palestine, it highlights pre-existing challenges in mental health provision. Before the pandemic, it has been claimed that among countries in the Eastern Mediterranean region, the country with the greatest burden of morbidity due to mental illness is Palestine, according to the WHO. Another paper was published in The Lancet in June 2019, concludes that in conflict zone, the estimated prevalence is 22.1. That's the point prevalence, 22.1% of the population, they need psychiatric and mental health services. Of course, we can imagine that with the pandemic, these numbers grow higher. One of the common problems in Palestine, Palestinians have a high fertility rate, and yet they have a higher prevalence of postpartum depression. So that's an area of public health intervention that is important. We talked about the deficiency in health staff in general, but mental health is even more marginalized among other health services. We see the number in psychiatrists, we see the numbers in comparison to other areas in the region like Lebanon and Jordan, and we see that the small numbers that we have. For example, in Jerusalem, in the West Bank, for a population of 3 million, we have 22 psychiatrists only. And in Gaza, we have only 10 psychiatrists. And we lost two of our colleagues during the pandemic. Nevertheless, the fact that we are very few, we created a national mental health response to the pandemic, and we shared tasks with other NGOs that are working in the field. We taking into consideration the need to serve people when they cannot come to the community mental health services. We provided hotlines and telephone consultations for people. We opened doors with our colleagues in Gaza and created a Wednesday webinar where colleagues meet and talk and exchange expertise and talk about developing a good response to meet the needs of the people who are affected, but also the health personnel who are burdened by this situation. I will go to my conclusion. Also, I want to say that in addition to the occupation, there are psychological challenges that we've been facing. There is denial, especially at the beginning of the pandemic. So people were wearing the masks and at the same time taking the mask and kissing when they were meeting each other. There was also at the beginning a conspiracy theory. So when people were asked to stay at home and close the mosques, they thought that this is part of the deal of the century. This is part of, they are doing that to facilitate the annexation plan. So the conspiracy theory is also inspired by the political reality. And they thought that the Israelis are asking everybody to stay at home so that they will take over the mosques. Also the stigmatization. The people were angry with laborers at the beginning because, as I explained earlier, Palestinians have no borders. So we don't have tourists coming to visit us. When we got the infection, it was through the Palestinian laborers who go and work within Israeli areas. So the Israelis travel abroad and they have the airport and they move a lot. But our sons and men who work as laborers, they go to Israeli areas, they were infected and they brought the infection to the household. So there was anger with the laborers at the beginning. And then the anger moved to the women who go to the wedding and infect everybody at the wedding. Let me end with a few positive images. People were also trying to be independent. Gaza, because they didn't have enough disposable material, they moved quickly to creating their own disposable material. In the midst of the confinement and the hard time, there were some volunteers trying to bring hope and pleasure to people in their homes, and people try to not stay away from the mosques, but maybe this image can be best understood by people who practice, people who are familiar with the Islamic ritual of praying, because you have to pray with your shoulders touching each other. But here, people are modifying the ritual so that they will do some kind of distancing. In conclusion, the pandemic is also an opportunity to address and redress the historic disparities in health and mental health in particular. Mental well-being is a national asset for Palestinians, especially for a nation like ours that has been robbed of its natural resources and whose mental health is targeted. So it's very important to learn the lessons from this pandemic and strive for equality and redressing all these disparities that we've been talking about.